Okay, so this topic has been like covered for us oncologists time and again. We have known that how beautifully the treatment has evolved over the past 10 years or so. We know that we have historically read that people have used drugs like interleukin 2 or interferon alpha in the management of advanced RCC, and they used to have dismal prognosis, dismal response rates of 6 to 8%. And now we are looking at drugs and or the combination of drugs where we are getting responses as high as 72%. So that's a big paradigm shift in the management of RCC. So here you can see that this is the landscape of this is how the management of RCC has evolved. Advanced RCC has evolved. So initially, there was sorafenib, then came sunitinib, pazopanib, temsirolimus, your pazopanib with a non-inferiority trial. Then came the usage of axitinib in the second line. Then nivolumab was the first immunotherapy drug. If you're discounting interleukin 2 and interferon alpha, this was among the newer checkpoint inhibitors. Nivolumab was the first drug approved in the second line. And now we have a plethora of a basket of choices to choose from when we are treating when we are going to treat the first line treatment for advanced RCC. We have a combination of IO in the form of nivolumab, ipilimumab, and then we have pembrolizumab, axitinib, and nivolumab, cabozantinib, and avelumab in combination with axitinib. So these are some of the pivotal trials that have come to define the current landscape of treatment of advanced RCC. So this is the trial compares. So we know that Sutent has been standard of care for advanced RCC after the usage of IL-2, high-dose IL-2 and interferon alpha. So pazopanib came into picture with this non-inferiority trial called compares. So here it was shown that the median PFS was the same in both the arms as well as the survival, with a better tolerability and better quality of life. Then we also have data for bevacizumab plus interferon alpha, but I guess I'll skip this because nobody really uses it now. Then we have data for cabozantinib in first line. This was the landmark cabozantinib trial, where it was used in IMDC intermediate and poor risk, and the comparator arm was sunitinib, which showed that not only overall response rate, but also median PFS was better as compared to sunitinib. Then there is the data for temsirolimus in the first line, and then this was the IO combination trial, checkmate, the landmark checkmate 214 trial, where a combination of nivo-ipi was used in the intermediate and poor risk, and the comparator arm was the standard of care sunitinib, where the response rates was greater, CR rates were greater, and so was the median PFS and overall survival. So the different immuno-oncology strategies in first-line treatment of RCC is a combination of IO, which is nivolumab and ipilimumab, and then there is a combination of IO plus TKI. So the various trials are your Javelin Renal 101 trial, which combined avelumab plus axitinib, and the comparator arm was sunitinib in almost all these studies. Then Keynote 4 to 6, after the combination of nivo-ipi, this was the second trial which got FDA approval. This tested the combination of pembrolizumab, axitinib. Then we have most recently nivolumab and cabozantinib, and then lenvatinib, pembrolizumab. This was the CLEAR trial where 3 arms were compared: lenvatinib, everolimus, lenvatinib, pembrolizumab, and sunitinib. So we'll mostly be focusing on the Javelin trial and some of the more intricate aspects of that trial. So here we can see that we are comparing the two trials, this checkmate 214 and Javelin Renal 101 trial. So in the combination IO arm, we can see that there is this PFS suppression is happening quite late, while in the Javelin Renal 101 arm, the curves of the two are separating very early. So as less as 2 months, with a median PFS of avelumab plus axitinib was 13.3 months versus 8 months in the sunitinib. So there you can make a conscious decision that if the patient has a very high tumor burden with a risk for early deterioration, and it is something where you'd want a good response rate and early response rates, because Dr. Akhil was initially mentioning that a lot of patients are such that they're not able to tolerate therapy, or they are not fit enough to receive the second line therapy. So that can happen here, that if the patient deteriorates very early, or it might not give us chance to introduce TKI in such patients. So there probably you can use this combination of IO plus TKI, where early separation of the PFS curve is happening. So apart from that, we also have to go with the right TKI selection. So how to select the TKI? It is not just in Indian scenario, cost used to be a big factor, but now that we have generics available for almost all of these three drugs with a relatively affordable costing now. So that thing has gone out the door, and we mostly focus on the toxicity, quality of life, the ability to maintain dose intensity. That is where probably axitinib comes into picture, that out of the three drugs that we are using, if we are using in the recommended dosage in the various trials, I think axitinib is probably the one associated with the best quality of life, the least side effects, and the least discontinuation rates. So axitinib is an ideal TKI because it has a selective and potent VEGF inhibition, so less off-target inhibitions and less side effects. And this label dose is 5 mg BD, and a lot of patients are able to tolerate. And in case of any combined toxicity, the half-life of axitinib is much short. So if you're stopping the drug and if you find that, okay, the patient is improving, you'll probably attribute it to axitinib rather than the IO arm. So you can see here how some of the side effects are quite common, like for TKI and these checkpoint inhibitors, hepatitis can be common, diarrhea can be common, hyperthyroidism can be common, arthritis and rash, and some of the unique toxicity we already know. So you can see the half-life of axitinib is 2.5 to 6 hours, while for cabozantinib, lenvatinib, and sunitinib it is quite high. So axitinib reaches a stable level in the blood within 2 to 3 days of the initial dose. Due to short half-life of axitinib, the plasma concentration rapidly decreases following treatment interruption. It's a very highly selective TKI with relatively fewer off-target effects. It mostly works on the VEGFR1, VEGFR2, and 3. While sunitinib, cabozantinib, lenvatinib, they work on other receptors as well. And that is why there are more side effects to those drugs. So this is the Javelin Renal 101 trial. This is the trial design. So they included treatment-naive advanced RCC patients with clear cell component. So they only included the patients who had clear cell histology. And these were good performance status patients, and they were randomized to avelumab 10 mg per kg IV Q2 weekly plus axitinib 5 mg in the standard dose, 5 mg twice daily. It was compared to the standard dosing of the sunitinib, and the primary endpoints were the progression-free survival and overall survival in patients with PD-L1 positive tumors, and key secondary endpoints were PFS and OS in the overall population. And additional secondary endpoints for overall response rates, time to response, duration of response, and safety. So if we look at the PFS in the intention to treat population, so this was 13.3 months versus 8 months in patients who had advanced RCC, while OS data was still not reached. And this is the PFS2. So PFS2 is basically, it is the time from date of randomization to the discontinuation of second line treatment or death from any cause, whichever occurs first. So in this, PFS2 was also significantly increased, and there was a 45% reduction in the risk of disease progression or death. So early introduction of avelumab also continued to confer benefit even when the patient had progressed and had been started on the second line. So improvement in PFS2 is a good endpoint, and you can see this waterfall plot. You can see that there is a overall response rates, that is your CR and PR, is as high as 52.5%, while a significant majority of patients demonstrated at least some degree of tumor reduction. While in sunitinib arm, it was just 27.3%, and the response was also faster. The median time to response with Vivencio and axitinib was 2.7 months, while in sunitinib arm it was 4 months. You can also see that probably the side effects, the rate of side effects, the various grades of side effects was almost similar, and there was no new alarms that were raised in combination arm. So this is these are some of the key points, that the patient had a longer median PFS with a consistent PFS benefit, And benefits in the subgroup analysis, benefit was seen in all the subgroups, irrespective of, based on the PDL status and all prognostic risk factor. Response rates was better, as well as it was faster, and there was a lower discontinuation rates, and the corticosteroid use to manage the side effects was also lesser. So this is the overall survival cross-trial comparison. You can see that most of these IO arms are doing slightly better as compared to the sunitinib arms. Although a cross-trial comparison should not be made, but here is something we'll talk about safety of the doublet arm in various trials. So you can see that in the Javelin arm, the rate of steroid use, high-dose steroid use was 11.1%, while in Nivo-IP arm was very high. We know that combination IO therapy generally is associated with much more severe immune-related adverse events. So the rate of steroid use is much higher. Even in Nivo-Cabo arm or the pembrolizumab axitinib arm, the usage of steroid was higher. Even the discontinuation rates were just 3.5% of either drug was just 3.5%, and then pembroaxitinib was also 6.3%. The discontinuation rates were much higher in patients who were treated with nivolumab cabozantinib. The reason being, cabozantinib is quite toxic. It is associated with a lot of side effects. Same goes for lenvatinib, pembrolizumab. And there was some degree of dose reduction that was also there in all the arms, while it was probably the least for pembrolizumab axitinib, followed by Javelin. So if we see the subgroup analysis of the various trials, you can see that the Checkmate 214, here the patients did not respond. The favorable group patients did not have a favorable hazard ratio for OS. Similarly, even for PFS, it was not there, and response rates was also less in patients of favorable group RCC. While in the Javelin Renal 101 trial, the patients, even in the favorable risk groups, they did respond, and there was a beneficial hazard ratio for not only overall survival but also for PFS. So overall response rates was also higher in all the subgroups in the Javelin Renal trial. In the Keynote 426 trial, again, you can see that for overall survival in the favorable risk, IMDC risk, it is hazard ratio is 1.17, while for PFS it is 0.76. And in the Checkmate 9ER trial, again, for overall survival, it has not reached significant. It is not significant, while it was significant for the intermediate and poor. Similarly, for PFS, there was significance in all the arms. So this we have already discussed, the rates of discontinuation. So a question often comes, like we know that some of these newer therapies are going to give response rates of as high as 72%, like for lenvatinib, pembrolizumab, and even for the Javelin trial, we have seen that response rates are 52%. But what about if the patient does not fall in that category, or if the patient did respond and if he did progress on the first line IO, then what do you have to do to treat such patients in the second line? So like after the introduction of first line immuno-oncology drugs, it is really a difficult decision to make for us oncologists that what next. But yeah, we can probably extrapolate the results of other trials or some of the previous trials of cabozantinib, axitinib, and we can make a conscious decision based on the patient's performance status, the patient's comorbidities, financial status, and things like that. So the various regimens available to us are your nivolumab, ipilimumab, the various other IO combination, IO-TKI combination, then the targeted therapies like cabozantinib, lenvatinib, everolimus, your axitinib, everolimus, pazopanib, sunitinib, and tivozanib. So this is some of the pivotal randomized trials in clear cell RCC, which have progressed post TKI therapy. So we have some of the better responses have been seen in the Meteor trial, which compared cabozantinib versus everolimus. And you can see that the second line or beyond, it had a better response rates, as well as the PFS was also improved, as well as the OS. In the nivolumab also arm, there was a significantly improved overall response rates, while median OS was improved by almost five months. And lenvatinib everolimus combination is also, it's a relatively toxic combination, but it does achieve a good response rates of around 43% even in the second line. And as compared to everolimus, it is achieving a median OS of around 25 months. So this also remains a in carefully selected patients, you can use a combination of lenvatinib everolimus with a carefully watching the side effects. So this is the PFS curves for various drugs in the second line. This is the cabozantinib everolimus, where there is a nice separation of the curves for lenvatinib everolimus compared to the lenvatinib or everolimus. In the nivolumab, you can see that the PFS curves are not separating, but yes, we know that for most IO drugs, immunotherapy drugs can lead to, even if fewer patients are responding, but if they continue to respond for a longer time, the OS data can show that, okay, the OS benefit is there. So now this is a phase 2 study. This is a keynote 146, study 111 of lenvatinib pembrolizumab after progression on previous IO therapy. We already have the first line data for lenvatinib pembrolizumab, but this is a trial where the patients have previously received, only 22 patients had not received any previous treatment, while no previous IO treatment was received in 17, and around 104 patients have previously received IO treatment for RCC. And median duration of treatment in such patients were 6.8 months. So here you can see that good number of patients have responded. Even in patients who were treatment naive, even in the patients who were treatment naive, of course, the response overall response rates were 72%, while IO naive patients, it was 41%, but it was TKI naive, it was 54.8%. So lenvatinib, and in combination with pembrolizumab, even in patients who have progressed on previous IO-based therapy, could be a decent option to use in the second line treatment. So there is no clear advantage of any combination, and these are some of the factors that you have to consider when you are choosing combination. Basically, what was the mechanism of action of the drug you used before, and the drug that you are going to use now. So somebody who has already been exposed to a TKI, maybe a combination, maybe an IO will be a good choice. Somebody who has already been exposed to IO plus TKI, I would probably be leaning towards everolimus, because it targets something else, some other pathway, combination of everolimus plus lenvatinib. And we always have to look at the toxicity profile of the patient. We have to look at the performance status and efficacy and safety. Thank you very much.